Stroke and traumatic brain injuries are some of the highest yield neurology questions you will be asked. If you can recognize just a few classic patterns, you can identify the stroke territories in seconds. Let's start off with the high yield facts about different strokes. Start with the ACA. The classic triad for this is contralateral leg weakness, urinary incontinence, and abulia. If you don't know what abulia is, it is a favorite buzzword that just means the patient seems unusually quiet, passive, and unmotivated. The ACA supplies the medial frontal lobe, and that's important because the leg motor cortex lives on the medial surface of the brain. As a result, the patient develops this weakness much more predominantly in the contralateral leg and foot versus the face and arm. The easiest way to remember this one is ACA equals ankle. Now let's move on to the most commonly tested stroke territory, the MCA. When you think of the MCA, I want you to think about the face and the arm. The MCA supplies the lateral cerebral hemisphere where the face and arm motor cortex are located. Patients typically develop contralateral facial weakness, contralateral arm weakness, and sensory loss. Now, a board clue that should immediately grab your attention is the word aphasia. Because the MCA supplies the dominant hemisphere language centers, including the Broca's area and the Wernicke's area, it affects the language. You have to know these areas because they are incredibly high yield. Wernicke's and Broca's aphasias are so high yield, but you're going to discuss each of them. So the Broca's area is in the left inferior frontal gyrus and the frontal lobe. It's usually supplied by the superior MCA, and its function is the speech production. You have to know what this looks like when a patient presents with Broca's aphasia. So these patients are going to be non-fluent, have broken speech, but they are going to have good comprehension. People tend to remember Broca's aphasia by having broken speech, non-fluent, effortful, but good comprehension. Wernicke's area, on the other hand, is in the left posterior superior temporal gyrus of the temporal lobe. It's usually supplied by the inferior MCA, and its function is language comprehension. And that is why in Wernicke's aphasia, the patient is going to be fluent, but their speech is going to be nonsensical, and they're going to have poor comprehension. People tend to remember Wernicke's by being word salad, fluent, nonsensical, and poor comprehension. Next up is the posterior cerebral artery. The PCA supplies the occipital lobe, which means that visual symptoms dominate. A board favorite is describing alexia without agraphia. So this means that the patient can write fluently but is unable to read what they have just written. They may describe hemipsia, which is a loss of half of the visual field. These patients also may present with vivid, colorful hallucinations of people or children. They may put this on the differential along with something like Lewy body dementia. Next, we are going to talk about Wallenberg syndrome or lateral medullary syndrome. This is one of the most famous brainstem strokes. Wallenberg syndrome typically occurs because of an occlusion of pica, which is a branch off of the vertebral artery. You need to know both of these because they may ask about either one. And this occlusion produces vertigo, nausea, vomiting, limb ataxia, hiccups, hoarseness, and diplopia. How you can remember Wallenberg syndrome is Wally picks a horse, which would be Wallenberg, pica, and hoarseness. These patients will also present with ipsilateral face numbness and contralateral body pain, temperature loss. A good rule of thumb is whenever different sides of the body are affected, think about the brainstem being affected. Now for one of the most devastating stroke syndromes, locked-in syndrome. Locked-in syndrome is a ventral pontine stroke, and it is most commonly caused by a basilar artery thrombosis. Now these patients are fully conscious. They can hear you, they can understand everything, but they cannot move or speak. This lesion damages the cortical spinal tracts, the cortical bular tracts. However, the reticular activating system remains intact, so the consciousness is preserved. The classic board clue is the vertical eye movements and blinking are spared, so the patient communicates by blinking. Let's switch gears and cover the hemorrhages that show up repeatedly on exams. Starting off with the epidural hematoma. For this hematoma, the middle meningeal artery is affected. People usually get these hematomas after a trauma to the temporal region. The classic board clue is a lucid interval where the patient looks initially fine and then rapidly deteriorates. On CT, there's going to be this lens-shaped hyperdensity. Next is the subarachnoid hemorrhage. This is the classic thunderclap headache. The patient often describe it as the worst headache of my life, and common findings include neck stiffness, vomiting, sudden severe headache. It's frequently caused by a rupture of the berry aneurysm. Whenever you see a thunderclap headache, think subarachnoid hemorrhage first. And then we have the subdural hematoma. This is usually caused by a rupture of the bridging veins, and it's most common in elderly patients and patients with alcohol use disorder because the brain atrophy stretches the veins. This is important for you to know. On the CT, it is going to be a crescent-shaped hyperdensity. They love to show pictures of these hemorrhages on the exams. Finally, let's talk about stroke management because you may get a question or two about this topic. So what is the first step of acute stroke management? First, you want to get a CT scan without contrast. That is a big deal that you will be tested on. It is essential to exclude hemorrhage before starting treatment. For ischemic strokes, you want to start aspirin within 48 hours to reduce reoccurrence and disability. And as far as TPA, it's indicated for new onset symptoms, typically within 3 to 4.5 hours if the CT shows no hemorrhage. So pay attention to the timelines on the exam because they love to test on these timelines for TPA treatment. To test your knowledge of neurology with board-style questions, click on the playlist and subscribe for new videos every week.